let's do Buerger's because it takes like 2 seconds. So, looks good. So if we're testing his pipes to make sure that he has good pipe flow, blood flow. And so if he doesn't, like for peripheral arterial disease, his abdominal aorta may be clogged up and he's not getting good blood flow here. And so I would have him take his shoes and socks off, but that's okay. I have x-ray vision. I can see right through these, but normally you would take your shoes and socks off. And you lift his legs up. You can help me a little bit too for my old bones. Lift him up 60 degrees. Are they still in the picture? Yep. And watch the bottom of his feet. Look at the sides of his feet. 60 for 60 seconds. And normally they might change a little bit of color, but they should not get ghostly white. Let's pretend one of them got ghostly white. So to confirm that finding, can you sit up for me now? Kind of facing that way. And then I just observe the foot, or maybe both of them got ghostly white. I observe them now to see how quickly the color comes back. If the pipes are clogged, it's not going to come back within 15 seconds. Normally it should come back 5-10 seconds. But it might take 20, 30, 40 seconds for the color to even return. And so that's an indication that the arterial pipes, not the venous pipes, are clogged. And there's really only two things that could, well, if there's a tumor or something clogging the pipes, but usually it's peripheral arterial disease of the abdominal aorta. If it's both sides, maybe just the common iliac is affected. And so maybe it would only be 1 foot then. Buerger's disease can also do the same thing. Okay, so that is Buerger's test. Let's see here. Let me zoom in. We'll do the modified Alen's test. Okay, so modified Alen's test, we're going to test the ulnar artery to make sure that it supplies the palmar arch. Okay, so it's very simple. This is the ulnar artery here. Can you pump your hands a couple times and hold it really hard? Hold, and I'm going to block both sides. Okay, now open and see how it's all grossly white. And now I just open the pipe up. Beautiful. See how it comes back in color? So we know that his ulnar artery is connected to his palmar arches, and that's nice. They really do this medically if they're going to do a catheter procedure and stick a catheter in his radial artery. That's going to occlude the blood flow. So that's okay if there's a double circulation, but in some people they don't have a double circulation. So if I stuck a catheter up that radial artery, his hand would die. Everything that's connected to the palmar arch, the deep and superficial, which is just about everything. So they always do that like a heart procedure where they're rotor-rooting out the coronary arteries. Now the Alen's test is exactly the same, but it's 2 steps. We're going to test the ulnar and we're going to test the radial artery. So pump it up, hold, block. Let's rotate a little bit for me. Okay, open it up, test the ulnar. Great. Okay, pump it up again. It's a 2-part test for the Alen's test. Hold, block it off, open, test the radial. He's got tremendous pipes. All right, so that's Alen's and modified Alen's. Let's see. Capillary refill test. While we're set up like this, you simply push on one of the nails until it turns white. Let it go. It should come back to color within 5 seconds. You can test different ones. This come back immediately. That would be another test for arterial insufficiency. Maybe he's got pain in his hand and you don't know. Maybe he had an injury in his forearm and he has a compartment syndrome maybe, and the blood flow is getting cut off to the fingers. So that's what you would use that for. All right, so that's pretty easy stuff. Let's go to, how about the heart? Yeah, let's work on the heart. So can you go face up again for me, please? All right. Let's see. So we got, I might ask you to find the apical impulse. So that's pretty easy. So I know right where it is. It's right here. You can use 2 fingers to find it. It's in the 5th intercostal space, mid-clavicular line. If you don't know how to find it, I used to teach this in first quarter. Oh, you got a very nice sternal angle of Louis. It's got a nice ridge right here. You go peace sign down. Sternal angle matches the 2nd rib. And so that's the 2nd, 3rd, 4th, 5th intercostal space is right here. So you would go out. And guys, not all the time, but it's often right in, like the nipple would be right here. It's usually right below the nipple in a guy. In a girl, they have that wire thing. It's usually right underneath that wire in the midclavicular line. All right? And so once you find it, you want to test it with 1 finger. And the trouble is you can only feel it in about 1/3 of people. And you can search around a little. Maybe I'm off one. I'm looking in between the ribs. Can't find it. But if you can find it, it should never be bigger than about the pad of your finger. I should never be able to feel it here. Let's pull this down. And I should never be able to put my other finger here and feel it. That's no good. That's a very strong sign of left ventricular hypertrophy. Probably from not wearing his, taking his blood pressure medication. And his heart is getting wrecked. Another way you could do it is you could go in the 5th intercostal space. I don't have my measuring tape with me, but I could measure 7 to 9 centimeters out. That's about in the midclavicular line there. 7 to 9 millimeters out from what? Centimeters out from the mid-sternal line. That's another place to find it. I think the midclavicular line, 5th intercostal space, is good enough. So that's finding the apical impulse. If you can't find it, there's a test that we can do. Your shoulder's good? Yes. Can you roll just, we're okay with the camera? Can you roll just a little bit toward the camera? And this is called the left lateral decubitus position. And then come on back, it's about 45 degrees. How do you back it up? You can just lift it and back it out. Thank you, Rob. All right, so it's going to shift it to the left. It's going to shift it a little bit to the left. But so you can't use the position, but you can still use the size of it. It still shouldn't be bigger in my finger. This supposedly increases the chances of finding it to 66%. Thank you. Face up. Okay. In a supine position, it should also not be way over here. So that would also indicate left ventricular hypertrophy. It should be right about here if you can find it. What do you do if you can't find it in either position? Then you got to use the old percussion trick. Let me see how this is doing on here. So the sensitivity is like about 50% on this. But nevertheless, they might ask you to identify left ventricular hypertrophy. So if you come over here in the midclavicular line, I'd probably be standing, let's see, I'm going to reach across on him, sorry. Because your fingers, when you percuss, they should always be in the same kind of plane as the ribs. You don't want them going like this on the ribs. So you could come over here and percuss up. So what's the normal tympanic note of the thorax? Is it tympani? No, this is tympani. This is called resonant. So you're looking to hit the cardiac region of dullness. So you want resonance to turn to dullness which should happen about in the midclavicular line. That's really like sensitivity and specificity is really bad on this. But nevertheless, if you don't hear the dullness until the midclavicular line, that means the heart probably hasn't expanded. If I hear dullness way over here, that's left ventricular hypertrophy, supposedly. They don't really do these tests anymore. The board books say to get rid of them, but they still mention them. So I'll show it to you. You just take a chest x-ray, right? If you want to see this, take a chest x-ray. Or send them to the hospital to do an ultrasound. Okay, are we good so far? All right, let's do the auscultatory exam. So I could say, or the board person could say, okay, I want you to do general auscultation of the heart. That means you're going to go through the apex monkey areas. All right, so again, peace sign, second intercostal space, you want to go right above the peace sign. Make sure you're not hitting the clavicle. Right, I always take points off if you're bumping into the clavicle because that's too high. First, you're like in the first intercostal space. You have to go down about a half a diaphragm length from the clavicle. Or if you do the peace sign, you can go right at the bottom of the peace sign. It's close enough. All right, so there's two ways to auscultate. Always tap to show them that you are using the bell or the diaphragm. So use the diaphragm. So there's a hopping technique and an inching technique. Both of the board books want you to inch so you don't miss anything. So inching, you will listen to the heart 1001, 1002, 1003, and just slide about a half a diaphragm length on that Z pattern. 1001, 1002, 1003. Slide 1001, 1002, 1003. Slide, and you can see it takes a while to do this.
Slide
half a diaphragm length should do the trick. This is called the inching technique, and both board books like this technique. So this is the way I would do it, and you're going to end up all the way over here. So you're going to do a Z pattern. All right. Some authors recommend a hopping technique. You might miss a couple murmurs, but if you're doing like 50 kids for physicals, it's probably good enough to hop, especially if they're low risk. And that's where you would hop. And the way when I would have tested you in lab, I would have had you hop. And so you will hop and name me the auscultation areas as you hop. So aortic, that's for all pigs. Pulmonic, about one diaphragm length down, that's Erb's point, which is a very important spot. Erb's point, that's eat. Then you're going to do a double hop. Not there, that's the fourth. Double hop, fifth intercostal space, that's 2 or tricuspid. And then much would be exactly the same spot where the apical impulse is. So that's the hopping technique. But you would still want to listen like 1001, 1002, 1003, hop. 1001, 1002, 1003, hop, little hop. 1001, 1002, 1003, big hop. Tricuspid now. 1001, 1002, 1003, hop out to the mid clavicular line. 1001, 1002, 1003. So that is general auscultation of the heart. Now usually what I do at that point, I say, you thought you heard something funny at the mitral region. How can you assess that mitral region a little bit better? If you hear something at the mitral region, the chances are it's going to be an S3 or S4 heart sound. So what you want to do, flip over, put this in the film here, flip it over. Does this even flip? Well, it's supposed to flip, but let's flip that over. Tap so you make sure you can tell the examiner knows that you can hear the bell. And then can you go back on your shoulder again for me? That's good, right there. Put them in the left lateral decubitus position and go right back to that apical region. And for girls, again, right under that wire of the bra. And you're going to listen and see what you hear. Okay, so that's checking the mitral area for S3 and S4 heart sounds. Okay, come on back up for me. Of course, the S3 heart sound is the ventricular gallop, which sounds like, I might have you clap out the gallop. F, I'm screwed. F, I'm screwed. F, I'm screwed. Classically, it's Kentucky, which makes no sense to me. Or yeah, that's the classic way it's described. I don't know who did that or why they did it. I like the F, I'm screwed. F, I'm screwed. Because then you got, we'll F you, we'll F you, we'll F you. So that's an atrial gallop. And that's an S4 heart sound, or short, long. That one's always pathological, so that one's no good. And both of these can be caused by hypertension for a long period of time. The S3 heart sound is only pathological in people over 40-ish, and it's, again, often caused by a stiff ventricle. Left ventricle, which could be also from hypertension. But for chiropractors, if you hear anything weird, refer them to the cardiologist. Let the cardiologist figure this out. All right. Then I could say, when you were doing general auscultation, you thought you heard something funny up in here, but you weren't sure. How can you assess this area? So to listen to both the aortic and the pulmonic valve, you always goes to Erb's point. So you want to go back to the diaphragm. I don't know why this thing's not turning, but go back to the diaphragm, tap, and then we want to set the patient up, bend them forward, and then listen at Erb's point, which is right about there. Erb's point is interesting because the aortic valve is under way higher pressure and slams shut. Pulmonic valve is not so powerful. And so the two sounds are about the same intensity at Erb's point. So it's a great observation post to listen to both the aortic and the pulmonic valve. And you can listen things like fixed splitting. Normally when you take a breath in, you suck a bunch of blood into the right side of the heart. It takes longer for that blood to pass through the right side of the heart. Therefore, you're going to get a stutter of the valves during the S2 sound. So it won't be like a, that was our S3. It'll be like so close that you can barely hear them. It's like lip-da-dub, lip-da-dub, lip-da-dub. That's called a fixed splitting. And that's okay. If you hear that, that's fine, as long as they're breathing in. But when they breathe out, that better disappear. That's called a pathological fixed splitting. When they breathe in, it's called a physiological splitting. So that's okay to hear that. But if they breathe out and you still hear that really close together, it almost always means an atrial septal defect, where Eisenmenger syndrome has not started. So you have a pathological flow of blood from here to here, and it's like the right atria is always filled up with blood, and that's exactly what causes it. All right, so that is about everything you need to know about the heart. And let's see, what else is next on the list? Chest expansion. We'll do, while he's still sitting there, we'll do anterior chest expansion. I think you guys were taught this a little different. Okay, move a little closer. I sure will. I won't post it on Brightspace, but I'll post it on my YouTube channel. They don't allow you to post external videos that are big. I mean, these are way bigger than, I think you can post up to 1 gigabyte, but these are way bigger. All right, let's do anterior chest expansion test. So you find the costal margins here, and you're going to take a tissue pull and pull the tissue in See how I'll try to get this down so you can see. See how that bunches everything up? And I got him. I'm hanging on to him pretty good on his ribs. Now take a deep breath. Deep breath. See how my thumbs go way apart? One more time. It works really good. Okay, so this test is good for pneumonia. If you think someone has pneumonia, let's say he's got some chest pain over here. Maybe you heard some crackles while you're auscultating. If you did this test, this one would go out. This one would be stuck and not do anything. Actually, a 44 positive likelihood ratio, 44 for pneumonia, unilateral pneumonia. This test is really good for that. And same on the back side. So that's the anterior chest expansion test. Let's see, what else?
Posterior, there's tactile, fremitus, posterior thorax, percussion, posterior thorax.
Yeah, we can do that. For percussion, for all your patterns, your auscultatory patterns, it's always an L-shaped pattern, a reverse L-shaped pattern. Like if you're set to auscultate for breath sounds, the anterior chest, get your bell out, and then you're going to go side to side. You should try to go up here in the supraclavicular fossa for the apices of the lungs. So just take like a little, not a like super deep breath, but a little deep breath and let it out. And I'm listening. Again, this should sound like rustling leaves. And then the key is to compare side to side. Okay, I'll just kind of speed it up so I don't want you to start getting dizzy. But you would do this side. And it's going to be weird here because the heart is here. And so that's why it's like, why do they even do this here? But you can certainly, the pattern is down on this side and out over here. And really, if you've ever been to your doc, the only place they really listen is down here. Because that's where you can hear things. Compare that side to this side. Maybe compare this to this. And then it's an L pattern. For tactile fremitus, you can, for a guy, you want to use your metacarpal phalangeal joints. There's a lot of research on that. These are better at picking up vibration. And so I could compare this side, and you could hear, could you say 99? 99. And then compare it to this side. 99. And it's kind of an abbreviated L pattern. 99. Can you say 99? 99. 99. And then go up here. 99. 99. You can really feel it vibrating nicely. 99. 99. And try to get up here. You can only use your metacarpal phalangeal joint up here. You can only use that one. 99. And then this one. 99. And if it's a female, could you grab your breast tissue and pull it up toward your shoulder on both sides? And all you can use is one metacarpal for females. 99. 99. You can still do the L pattern though. 99. 99. 99. And you just kind of do the best you can for them. 99. Don't forget the apices. 99. And I can feel it vibrating pretty good. Okay, so that's fremitus. Percussion really we don't really do here. If they asked you to do it, we don't do it because you can't percuss this side of the heart, is impossible to find. And then we have the liver here, so that we really don't do a general percussion. But if they did, you would do the same pattern. Percuss side to side, checking the L. This side to this side. Heart is there, so it's going to, of course, sound dull there. Compare that. No, you can do the whole exam to each on each side. And now let's see. For the posterior thorax, let's have you sit up facing me. All right, so let's do this diaphragmatic excursion here. I don't know why I tell I can't. I'm so foggy I can't see anyway. Okay, so let's picture what happens to his lungs. Take a big breath in for me. What happens to the lung? The diaphragm drops down. Blow the air out. It raises up, right? Physics 101. The distance between here and here is called your diaphragmatic excursion. And that should be, I think it's 3 by 5 also. 3 by 5, is it centimeters or inches? Centimeters. So here's how you do this. So first of all, we want to measure the bottom of the excursion. So can you take a deep breath in for me and hold it? So the diaphragm drop down, and you're going to percuss down. Resonant, resonant, resonant. Pretty dull right here. Okay, go ahead and breathe. Take your drawing pencil and go draw a line right there. And let them recover a little bit. Okay, there's the diaphragm. Okay, now take a little breath for me. Blow the air out. There the diaphragm goes up. And now come down and repeat. Hold for me. Okay, it sounds a little dull there. Take my pen, mark it, and go ahead and breathe normally. And then get your measuring tape out and measure that. And that's like 4 centimeters. This one is hard. It's really hard to really hear the difference. So you might have to hallucinate a little bit in there to get this one. And then you repeat it on the other side. Exactly the same. And it should normally be 3 to 5 centimeters.
So you just have them take a deep breath in and then...
Yep, so first you want to get the bottom measure. Take a deep breath in, that drops the diaphragm down. Make sure you start up high enough. Come down, resonant, resonant, clunk, dullness. Mark it, have them rest for a second. Now blow the air out. That's going to push the diaphragm up to blow the air out. And then come down again, looking for the new position. They have to hold their breath though. Mark that, and then relax and breathe. And then get your tape measure, and it should be between 3 and 5 centimeters. That's a normal diaphragmatic excursion. I think some athletes have up to 10 centimeters. Some athletes have really huge excursion, which is fine. Anything that pushes the liver up or this side up, like cirrhosis of the liver, will shrink your excursion. Anything that pushes the top of the diaphragm down will shrink your excursion, like COPD. That can do the same thing. So COPD can push it from the top. Hepatitis causing cirrhosis, causing hepatomegaly, can push it up. And it can shrink that excursion down to too low. Let's see. Let's do chest expansion back here. Okay, so his lats come down about here. So you wanna really grab him out here, and let's see, how's that? Looks pretty good. And then take a huge tissue pull. See how his shirt is bunched up? Now take a deep breath for me. Thumbs expand really nicely and back. And you're looking for symmetry. There's no measurements here. All right, and the same deal. If he's got pneumonia, this one's not going to move. If it's got pneumonia in the left lung, not going to move much.
What grip are you trying to...
It's down pretty low, probably T10-ish, 9, 10. You don't go like this. I've seen this before. You don't go like this. You got to take a tissue pull in, and you got to grab them. I got them. Now take a breath for me. And that works really, really nicely. And there's no measuring here. I don't know where that came from. But none of the books, not even Jarvis, says to do any measuring. You're just observing for symmetry. That's about all that you can get out of that.
And this one is also like good testing for pneumonia?
Yep. So what really good for testing for pneumonia, 44 likelihood ratio is crazy. If he's got unilateral pneumonia, this test will be positive. This won't move. It'll be all stuck to the pericardial cavity. And what goes along with pneumonia, there might be some fluid in the pericardial cavity or the pleural cavity as well. So pericarditis can also make this test positive. Big one is pneumonia though. Let's see.
Percuss the posterior side?
Percusses that same L pattern. If you look back in the notes, you'll see it. So percussion is, if you're asked to percuss the posterior thorax, 1, 2. Compare that side. Compare these two sides together. Compare these two sides together, etc., etc. But don't forget down here, this is the most important one. Come out here at the costal phrenic angles. I might even go to the other side, but I won't block the view. And percuss these view. So if you have a tumor or something, there's going to be a difference. You'll have a thud rather than the resonant type percussive note. If you're asked to auscultate posterior thorax, exactly the same pattern. Compare here to here, and you'll have them take like a shallow breath in. Compare here to here, going down on that L here to here. Some people drop down, that's fine, as long as you're comparing side to side. This side to this side. This side to this side. And then costal phrenic angle to the costal phrenic angle here.
Do you do the tactile fremitus on the
Tactile fremitus, you can use an abbreviated. It's like you can skip every other space. So say 99. Go down to here. Drop down to here. Out here.
So if they ask us to do that, we would do, and in general, you do anterior first, posterior second?
They'll tell you which one. They'll say do anterior tactile fremitus. In the real world, you don't do this at all, I don't think. You just order an ultrasound. Yeah, but unless you're out in the woods in Alaska or something and you don't have any other tools and this is all you got, then you would do the entire exam on the posterior side and flip them over, do the entire exam on the anterior side.